Hello from GCOS 2019 from Sao Paulo in Brazil. I'm Joerg Herrmann, professor of medicine at Mayo Clinic in Rochester, Minnesota, consultant in the Department of Cardiovascular Medicine and the director of the Cardio-Oncology service line. And I'm here with Mike Fradley.
Hi, how are you doing today? I'm an associate professor of medicine at the University of South Florida and at Moffitt Cancer Center in Tampa, Florida, and the director of the Cardio-Oncology program at those institutions. So, Joerg, today we're hearing a lot about tyrosine kinase inhibitors and some of the cardiovascular toxicities that are associated with them. Can you give me some updates about some of the vascular issues that we're identifying with these agents?
Yeah, the tyrosine kinase inhibitor is a very successful line of drugs, and for the new drug pipeline, I mean, among immunotherapies, they're the ones that are still front line. And unexpectedly, as it has been the story with these targeted agents, we see toxicities that were never expected. Well, to a degree, you might say with VEGF inhibitors, why did you not expect some vascular issues?
Sure.
So that wasn't totally a surprise, but the surprise was more with those BCR-ABL inhibitors that are used in patients with CML. So ponatinib and nilotinib are the ones that have raised particular concerns. More recently, also dasatinib. Now, the molecular fine print as to why this is not fully defined. There are some interesting experimental models, and I think the takeaway from this is that nilotinib, ponatinib for sure, have VEGF inhibitory elements. And it might be that it's in fact mediated through the ABL pathway. And very interesting, just to make a point, is that it was not just one tyrosine kinase that was the culprit when they inhibited these targets that nilotinib aims for individually, but it was the combination of these. And I think that tells you a little bit about the complexity. We always thought about the sentinel kinase, the one kinase that is the target and is responsible for all the side effects, but it's not as simple. I think it's a complex interplay.
Mm-hmm.
And that reminds me, Mike, what about, I mean, your area, where you're very familiar with, the arrhythmias, and Ibrutinib.
Mm-hmm.
What's the latest and greatest with Ibrutinib? It can cause some harm too.
Absolutely, and I think that Ibrutinib, similar to some of these agents that you've already described, we're starting to recognize this increased risk of cardiovascular toxicities. But interestingly, with Ibrutinib, it seems to be more of an arrhythmic cardiotoxicity as opposed to vascular or perhaps heart failure. Ibrutinib is a small molecule inhibitor of the Bruton's tyrosine kinase, and has certainly revolutionized the treatment of a lot of these B-cell malignancies, particularly chronic lymphocytic leukemia. But rates of arrhythmias with this drug are anywhere of 10 to 15% of patients who take this medication. It also leads to a lot of bleeding complications, which causes a lot of complexities in how we manage these individuals. And that really, I think, speaks to the areas that really require a lot more investigation. We really need to start to understand the mechanism behind Ibrutinib-associated arrhythmias, as well as better understandings of Ibrutinib-associated bleeding. That's crucial for us to develop appropriate management strategies for these patients. Also, it doesn't just end at arrhythmias with Ibrutinib. We see a lot of hypertension with these patients, and there's actually been 2 recently published studies that have shown that these cardiovascular toxicities actually lead to serious major adverse cardiac events. So there's a lot of need to understand why this happens and what we can do to mitigate the risk.
Now, Ibrutinib, I mean, doesn't it inhibit platelet activity?
It does. So it inhibits platelet aggregation through the glycogen 6 collagen pathway. But there's also some other potential mechanisms by which Ibrutinib can lead to bleeding. It also interacts with glycoprotein 1b as well as von Willebrand's factor, which then affects the ability of platelets to adhere to damaged blood vessels. So we do have some understanding of how ibrutinib affects bleeding, but I think that we still need to investigate that further as well.
Because just what you mentioned, I mean, some suggested based on that that ibrutinib would be the best aspirin ever for patients with cardiovascular disease, right?
Absolutely.
I mean, plaque rupture. I mean, what do you think about that?
It really is a fascinating question, actually. Not only from a vascular standpoint, but also raises the question: does ibrutinib actually provide a protective benefit from thromboembolism associated with atrial fibrillation?
Mm-hmm. Right.
Perhaps these patients wouldn't require as intensive anticoagulation strategies that a person who developed atrial fibrillation for another reason may require. So really, really interesting questions.
What about the VT events, right? Because there are also some reports on that.
Correct. Ventricular arrhythmias are also now being increasingly recognized. There was a nice study that was recently published suggesting that the rates of ventricular arrhythmias were rare, around 596 per 100,000 person years, but still significant, and obviously ventricular arrhythmias lead to a lot of serious outcomes. And I think that from, again, a translational science standpoint, understanding the mechanism of both the atrial and the ventricular arrhythmias, there might be a similar pathway that might explain why ibrutinib leads to those problems. Now, interestingly, other BTK inhibitors do not seem to have the same rates of arrhythmias as ibrutinib, so there may be off-target effects from which ibrutinib causes its arrhythmias. But I would also say that I think the jury is still out as to whether these other agents may or may not lead to elevated rates. It's just that we don't have as much experience with them, and over time we may start to see more cardiovascular complications with them as well.
Yeah, so with the vascular events with nilotinib, ponatinib, it's in the order of maybe 10 to 40%. So it's a larger population, and that might make it easier to screen, because that's the other question clinically, is now we know about these risks, we hear about these, what do we do clinically, and should we be proactive in a way? I know the package inserts, they always have a long list.
Mm-hmm.
Some of them are labeled for QTc prolongation. In fact, nilotinib has a black box warning.
Yeah.
And there are recommendations as providers should adhere to, as doing regular ECGs and then react to it. Now, I can tell you, at least at my institution, we've done a retrospective study. It's not always the case that providers react to that. It's
Yes.
not always the case that they even take an ECG. So how can we address those issues? So what would you suggest? I mean, let's, with nilotinib or ibrutinib, I mean, those arrhythmic risks, which can be really sudden.
So that's a great question, and there's obviously a lot of controversy surrounding QT interval assessment, how to do it accurately and such. And I would say that with nilotinib, there is a lot of concern surrounding its QT interval prolonging potential, but its actual risk of serious ventricular arrhythmias is extremely low. I think it's an interesting question about ibrutinib. We don't necessarily get baseline ECGs in these patients, and perhaps that's something that we need to think about in order to determine where they are before starting the medication, and then follow that over time to really better quantitate arrhythmic risk in those patients. And I think you bring up an interesting point when it comes to both risk mitigation and monitoring. For you in these vascular toxicities, are you initiating any sort of protective medications in patients that start on these, for example, statins, given the vascular toxicities associated with them?
Yeah, we try to control the risk factors as much as we can and as aggressively. And then mechanistically, if this is going through the VEGF pathway, affecting the endothelial cells predominantly, then you would do everything to improve that endothelial health. And so statins are a key component. To a part, ACE inhibitors have been shown, amlodipine adds to it, and exercise. Now the interesting aspect about nilotinib is, to a degree ponatinib, is that it affects the lower extremities.
Mm-hmm.
So ABIs, I mean, that's a pretty cheap test that you can do serially. so is ECG.
Sure.
And but as alluded to, providers sometimes don't do it, and I think that's an important message too, clinically. And we won't go into the discussion preclinically as how these drugs should be tested, because that's another thing. Right?
Absolutely.
A lot of these are released just based on phase 1, phase 2 trials, and we just learn about these tyrosine kinase inhibitory spectrum in clinical practice. And so there's much more to learn.